Hi, welcome to the Dog Dave Show. I'm pleased you've joined us today. On the show today, we are talking about a condition which is quite debilitating for most people. It's called fibromyalgia. The reason why we brought it up because it affects many systems of the body and it affects people in various ways. And the worst scenario is we cannot measure the condition. We cannot measure the severity of the condition. It's what the patient tells you, how they are feeling. That is important. So today we thought maybe on the show we should bring Dr. Fayez. Dr. Fayez is a rheumatologist, well known for his ethical and clinical work, and he has kindly come to the show, and we are so pleased to have him on the show. Dr. Fayez, thank you so much for coming to the show.
Thank you very much for inviting me.
Yeah, now this condition we are talking about is fibromyalgia, and I know it's a big word for most people. How about we break the word so that for the layman they are able to understand what do you mean by fibromyalgia?
Like it is, there is no definitive literal meaning from its symptoms and variety of issues with this condition rather than the term fibromyalgia. The simple way to tell it is myalgia means muscle pain, and fibro means fibrous tissues, but it doesn't correlate with the literal meaning. It's a complex of symptoms what patients really suffer from. At most of the time they suffer from some degree of pain. Could be nerve related, could be muscular, could be bone pain. But this is not only the pain, it is associated with extreme fatigability, easy fatigability, and associated with many patients feel that they are not having their good memories that like they used to have. They are losing concentration, they are losing focus, and associated with a few other physical symptoms can make it complicated.
That's right.
It's basically, in simple words, is a complexity of symptoms. That's makes it fibromyalgia.
Yeah, that's right. So most of the times a patient comes, let's say, to my clinic as a family physician myself, and they come with, I got muscle ache here, I got joint ache there. You know, sometimes it's difficult to say this is fibromyalgia. Sometimes, I mean, there's other conditions that mimic the condition. At what stage then, or what is the diagnosis criteria, should I say? For that?
Look, this is a clinical diagnosis. There's no definitive diagnostic test for it. We need to think about the complexity in a way. Every symptom has got a background pathology. Except for fibromyalgia, we don't find any background pathology or definitive issues when the patients have symptoms. So investigations are usually normal. But when patients complain about symptoms, we try to exclude related symptoms, whether there's an underlying pathological conditions. So in fibromyalgia, when patient comes and tells us symptoms, we try to rule out the possible pathologies and then figure out whether it is related to fibromyalgia or not.
That's right.
There's really a long-term issue with the diagnosis, the complexity, and many of the time when the symptoms comes, we try to put it on fibromyalgia, but not all the cases are like that. There is possibility. You can have other diseases as well as fibromyalgia. So the two things need to be distincted from one from the other. So one of the major issues, normally we say the people sometimes have inflammatory conditions like rheumatoid arthritis or systemic lupus erythematosus. And these patients we see very often in our work experience-wise suffer from some degree of fibromyalgia. So that's why we usually get quite a lot of fibromyalgia patients for ourselves. We exposed to. But these are not precursor for fibromyalgia. Fibromyalgia can be coming with many other reasons. And they may not have any underlying pathology, may have underlying associated pathologies, but they can come as a group of symptoms in general.
Right. If you look at the gender type of scenario, I see that it's predominantly in females.
That's correct.
In fact, I haven't got any male patient who's got fibromyalgia, but I got a whole group of females. And most of them are kind of middle age plus. Is that the scenario across the...
That's correct. It is the most common patients we see in the middle, early middle to late middle age female patients. But these are not only the groups. We see younger people and older people. Males are much less common,
Yes.
but we see them.
Yes.
And the onset is very difficult. Many of the time that was postulated whether hormonal change has got anything to do, but there's no cause has been established.
Yes.
Having said that, many of the autoimmune diseases are more common in females than males.
Yes.
So a lot of hormonal issues has been suggested, but no proof has been found.
Yes. Yes.
Many of the time it has been postulated that way. The way the females work probably more physical than males, whether they may suffer more
Yeah.
than the others, because in general we see that males probably do physical work more, but females do lots of works around the house and variety of things they do.
They do, yes.
Whether that has been affected in some way, it is hard to tell.
Is there any genetic pattern to this?
Not well established. In fact, there is no cause we know about it. So genetic cause cannot be ruled out because we don't know.
We don't know, yes.
We have seen few cases where they have family history, like a patient has their mother or their sister has got the similar issues. They also get concerned and they try to come and rule out the possibilities.
Yes.
In some cases, we see that the index patient may have fibromyalgia, and there could be correlation between the family members.
Yes. Now, so, okay, a patient comes to me. At what stage should I refer to you? Immediately, or should we say it's duration-based scenario? I mean, the patient is coming with multiple painful muscles of different spots over a certain period of time. Then maybe we're looking towards fibromyalgia. Or should I just quickly say, oh no, I've ruled out A, B, C, D. I've done all my inflammatory markers. Everything's come back normal. Maybe sometimes we have to do some X-rays here and there if it's warranted, if it's needed to rule out arthritic. Should we say we refer? At what stage should we refer?
A very good question, David. This is a very difficult scenario, especially when the patients come, because patients don't know anything about it. And it is very difficult because the complexity or the variety of symptoms are so wide. It's hard many of the time to what way to investigate. Yes, so initially we suspect this is the case, and then we try to rule out the other possibilities. I feel that that is the first thing to do. So when the patient comes in to yourself, I think the first thing to do, rule out the symptom-related pathologies. And if it is normal and the patient's symptoms are severe enough, certainly I think a referral would be a possibility. But one important thing to remember, the treatment-wise, as we do the same way. So we think about pharmacotherapy is one of the major part of the treatment, but non-pharmacotherapy has got a major role as well. In fibromyalgia particularly, I do very little about pharmacotherapy. Non-pharmacotherapeutic measure is much more important, and patients need to understand the condition very well. So when a patient comes to me, I took quite a lengthy of time to discuss with the patient, to educate about the condition. I asked them to read about it, learn about it, and to be very careful to look at in the internet and what websites they're going into. That's where many of the time people...
They should come to this show.
That's correct. Many of the time I ask them to be careful what they actually reading and learning about.
That's right.
That's very important. If you're reading wrong, you're going to wrong websites, you get wrong information.
That's correct, yeah.
So I tell them most of the time institutional websites, renowned institutional websites most of the time has got very good information. So they know about it. Once they learn about their condition, they actually feel much more confident about it.
They feel much in control.
That's correct.
Symptoms.
That's correct.
Symptoms of which you're going to talk now in more details. So we talked about the general muscle aches. How do you pinpoint, or how do you put in a category slot? Okay, I was looking at the American website, and one of a good website, a rheumatology website. They say you must say painful spots. I mean, you have to count them.
Yep.
And they are scoring out of what? Out of 18, is it right?
That's correct.
Yeah.
We actually stayed away from it. That is these classification criteria we have been using in the past. But one of the most important things to remember when you are poking into these pressure point, many of the patients actually get more symptoms, especially after the examination. So many of the time, many patients find that doctor, you examined me, and I got worse after that because all the pressure point has been stimulated. Right. So current diagnostic criteria actually stayed away from the physical pressure points, examination. It's mostly symptom based, which is actually also debatable. That only symptom based diagnostic criteria. It's not classification criteria, diagnostic criteria, which came out in 2010. And they mention about mostly symptom, how severe is their pain, and how extensive their pain, as well as the fatigability and duration of the fatigue. So those are the criteria we now use to diagnose fibromyalgia. And there's a clear indication is there. It does not rule out having any other diseases. So there could be a coexistent disease, and that there could be fibromyalgia as well. So fibromyalgia does not get the influence onto the disease or vice versa.
And you said about, there's so many symptoms, and one of which you talked about maybe disturbance in the memory or maybe mood swings or something like that. I've seen that a lot.
Yes,
these kind of psychiatric symptoms with every fibromyalgic patient.
Yes.
I'm not sure exactly. This is where, that's the pitfall we jump into, most of us now as clinicians.
Yes.
Now we say, oh, that's your anxiety, or, that's your anxiety, so let's treat anxiety rather than admitting that there is this is fibromyalgia, and there's a constellation of symptoms, and this is just one of the symptomologies. But we just dismiss it. And if that's anxiety, you worry, okay, do that. And of course, you can start some antidepressant, anti-anxietytics, but that is our main pitfall. And do you see this all the time, this psychiatric component with your patients?
Yes. I would say almost everyone. Not necessarily they have to have major depressive illness or any other psychiatric illness or anxiety disorder. But as you know that when the symptoms goes for a time, patients automatically start feeling within themselves. And another pitfall is many of the time their primary clinicians or their family members or neighbors or friends actually try to dismiss their symptoms.
Yep.
That makes a really a big anxiety for the patients, and they start thinking whether I'm making it up or whether nobody can picking it up or what is happening. They're getting nervous. So anxiety and mood disorder is very, very common, especially who has got a moderate length of time who is suffering from. And it is part of the actually management to understand that if you don't control the mood, the improvement is limited because there's no insight or no initiation from the patient themselves to get better. Okay, it is a positive way you need to move. So if you don't have a good mood within yourself, you can't move positively. So it is very important actually to manage and treat the mood side of it. Not necessarily everybody needs antidepressants.
No.
They may need some psychotherapy and psychologist review on a regular basis, and probably need a support from the family and friends as well. So in many patients, I ask them to bring their family members with them so that they understand the whole thing. So it is not a single patient or single person's management. It is the concept actually we need to change among this in the society as well.
So stress management basically.
Is one way this is. It is.
It's going to be emotional stress, could be work, could be relationship.
That's correct.
It could be lots of things, that would trigger there may be these symptoms.
Exactly.
So we can manage the stress, maybe that might help. And like you said, I mean, physical therapy might also help, like hydrotherapy, for instance.
Yes, hydrotherapy is very good in a way. I have found probably in my career that 1 or 2 patients who didn't tolerate water or hydrotherapy, predominantly because of their intolerance to the water or the chemical compounds in the swimming pool.
Right.
Usually heated pools are very good. Their muscle get relaxed, the weight is away, and the activity is much better.
Yes.
So yes, it is very important, physical and hydrotherapy. The other most important thing I should have mentioned is the quality of their sleep is always affected, and we need to pay a real focus on their quality of sleep. One of the things we need to try to exclude whether they have sleep apnea or not, because poor quality sleep may bring the similar symptoms. And I think clinically, I mean, before going into any investigations, clinically you can suspect whether there is sleep apnea or not. And if there is a suspicion, they should have sleep studies. But quality of sleep actually makes a difference to their symptoms. In simple way, I can explain that if you have 3-4 sleepless nights, you'll feel very tired. And that's what happened to fibromyalgia patients. They always feel restless, tired, fatigue. And if they have a better quality sleep, their symptoms actually get better.
Gets better, But the poor sleep now compounds the fatigue from fibromyalgia.
That's correct.
They can't be functional during the day.
Right.
They can't do their day-to-day activities, and just makes the scenario worse. So that's a good thing. So I don't know. I haven't seen any, but there's a mention that some people can prevent with constipation and stuff, gastrointestinal issues.
That's correct. It is very common actually. Gastrointestinal symptoms. I mean, most of the people find they have got irritable bowel. So sometimes they have got constipation. Sometimes they have got a bit loose, but there's no features of inflammatory bowel disease. It's more irritable bowel symptoms. Many of the time they complain about tummy pain when they have their meals and things they can't tolerate. They feel a little bit sick at some stage. But as you know, that this can open up a completely new door, whether not necessarily related to fibromyalgia, it could be some other symptoms. So it is there.
Well, regarding pain, the one thing I've seen again, which is very common, is this kind of scenario whereby they feel like they got pins and needles in their hands in particular. They feel like somebody's pricking their hand. Again, it's subjective. It is what the patient is telling you. And how do you approach that one?
Look, it is very important when the neurological symptoms patients getting. I feel that many of the patients, by the time I have seen, there's a huge concern before whether they have got multiple sclerosis or something. Those issues come, but I think it's very important to identify the complexity of the symptoms. Pins and needles, their localization, their dermatological distribution, and everything. If you calculate, as probably most of the cases, you can rule out whether there is a central neurological symptoms or peripheral. So identifying and differentiating them is very important. And when you can differentiate that, I think it is much easier and explain to the patients. So it is most of the time clinically you can isolate.
No, that's okay. So we talk about fatigue, we talk about abdominal symptoms, cognitive function, stress, distressing, the importance of physical therapy, hydrotherapy, cognitive behavioral therapy with the psychologist. That's all that will help. Any kind of therapy, pretty much. Physical therapy is good for the muscles and stuff. But most people, they're saying they are reluctant. That's the key component for managing fibromyalgia. Like you said, you don't like the pharmacological approach. You'd rather go for the physical therapy approach. And yet, that is what the patient don't want.
That's correct. So, as I said, when I see my patients, I give them a time and explain the whole thing. One of the major things I'm telling patients nowadays that we don't focus on the symptoms. We don't focus on the symptoms much because we cannot change the symptoms a lot with physical therapy or pharmacotherapy or cognitive therapy. They are constant. So if you understand that, that if you're not able to change the symptom complexes, what we are doing then? The main thing we're trying to do is improving the patient's quality of life.
Yes.
So the constants remains in one side, and we ask the patients, improve your functional capacity. If you focus on the symptoms like pain, we're giving a lot of painkillers, or their fatigue, we try to give them steroid on others, which shouldn't be, and they can feel temporarily better, but eventually find the symptom doesn't really change much. What we try to tell them to improve your physical capacity, improve your functional level, improve your cognitive level, that's what we should be focusing on. And many of them doesn't need functional therapy. We use the pharmacotherapy time to time just to minimize the symptoms or control the symptoms when it is out of control, but it is not the primary factors. And nowadays what we see, there's different type of pharmacotherapy. Patients come and ask or inquire about different kind of pharmacotherapy. We try in some of them, but I always tell them that the symptoms you have, unfortunately, it may be for the rest of your life. So you have a new platform to start on. So you have a baby steps when you're children, young child. Now you have got a new phase. You need to start learning your baby steps and then move forward. And you have these symptom complexes will be part of your life. So once people understand the concept, then it's much easier for them to move forward. But I think the expectation wise, I always tell them, look, I think it is very difficult to tell whether and how much we can improve your symptoms, because they always will be constant.
Yes, yes. That's very good. That's good. Anything else you want to tell for the people who are watching?
Well, I think best thing I can tell that if you are concerned, it is better to talk to your doctor first, and rather than getting anxious and things, take a positive approach. And if there is a suspicion of fibromyalgia, I think it is all you can improve your quality of life rather than anxiety, which should not be a major issue. I also tell them that fibromyalgia, we haven't found any pathological pathology that is causing damage to your organs, and it's not known to reduce your lifespan. So if you have to live 100 years, you'll be living 100 years, but you might have the symptoms going into you.
Yeah, it's not a death sentence.
Not a death sentence. Like any other diseases, by definition, the disease means that it has a etiology. It has got will cause some damage into organs, but fibromyalgia is not necessarily will do that. There has been some investigations has found some changes in the nerves, central nervous system and peripheral nervous system, but what's the implication on these organs, we couldn't figure out, we couldn't find. So still we believe there's no pathological implication on the organs from the fibromyalgia.
Wow. Dr. Fayez, we're talking about the fibromyalgia. Let's say I refer a patient to you. Say, okay, Dr. Fayez, I'm a bit confused. I don't know what's happened here. The patient keeps on bouncing back and the same symptoms. I send the patient to you for your expertise, basically. What happens? How do you take it off from there?
Look, I think the most important thing I do is listen to them, and I ask them to tell their story. And within the first 5 minutes, I found that 95% of my patients actually burst into tears.
They cry.
They try to control, yes, they cry, because they have been trying so much to find out what's going on. Either, as I said, that their symptoms has been dismissed, or nobody would wanted to give any symptoms. On the other hand, they have got social embarrassment. There is dispute in the family. Family doesn't want to hear or understand what's been happening.
Yes, yes.
So lot of emotion runs.
Right.
So I tell the patients that if they're feeling emotionally upset, I ask them if they want to cry, you can cry. Right. Because my table and chair and myself is witnessing a lot of the similar stories.
That's right.
So their emotion is very important. When they are happy to run their emotion down, they actually feel a bit relaxed. And it is a common phenomena.
Right. So do they cry when you give them the diagnosis, or
No.
or when you acknowledge their symptoms?
No, it is not when the diagnosis. Diagnosis come towards the
Yeah,
end
yeah.
when they discuss the things. It is
Yeah.
when they're telling their stories.
They're telling their stories to you.
They are so upset and frustrated that nobody can tell what is happening.
What is happening? Yeah,
So
yeah.
it is a huge number of the patients
Yeah.
do have the similar kind of
Yeah, yeah.
sort of emotional changes, I see.
That's right. Yeah, I think most of it because, like I said, it's not. There's nothing you can measure to say
That's correct.
this is how you feel.
That's right.
I can say I can have pain here, but pain is what the patient tells you.
Exactly.
It's subjective. So
Exactly.
So for most people, they won't acknowledge that. They just dismiss it. It could be a partner, it could be even friends. They say no, that's something else, or maybe it's anxiety, maybe you're just a warrior kind of story. So to have somebody to acknowledge that they are in pain, to acknowledge that it's a huge, makes a huge difference to the patient.
Yes, that's true. But as I said, that even before I acknowledge, it actually the emotion comes out with their lengthy symptoms.
Wow.
And if you ask them to talk, and I see it's automatic things. They actually going the same path almost all the time. The emotion comes out. And I think that's where it is that if we give them a time, the patients needs time. I think in reality, a patient of rheumatoid arthritis, the amount of time I need to spend, a fibromyalgia patients, I need to spend double the time.
All right.
Because I need to learn about the symptoms
Yes.
and things, and they have a lot of things to tell.
Yes, yes.
And that's why they should be able to tell their story. And most of the cases we can't really afford to give them a lot of time. And that's why the other issues like physiotherapy, psychotherapy, everything is coming to the control, and they need all the support from every aspect,
Yes.
including the family,
Yes, yes. Yes.
to provide them the support to make it better.
Do you give them a diary to go and
Yes, I do. I do tell them to keep their symptoms diary, but it is not a daily diary. There is a pitch and falls about this. I usually tell them to keep a weekly diary in general to benefit from that. So one of the benefit I tell them, then when they keep the symptoms diary, number one, they try to remember their previous week what happened. So
Yes.
that's a stimulation of their memory because they have a memory issues most of the time. And at the same time, I tell them to find out, if they can, if there's any precipitating factor for that.
Yes.
So that can identify them what it is. Many of the time, they're probably doing a little bit too much work. They mow the garden, then clean the whole house, then they have the symptom flare. So if they can recollect those symptoms and relation between the symptom flare and the activities, they can also pinpoint. But at the same time, in the first few months, they may not correlate anything.
Yeah, that's right.
So I tell them, you keep writing those and try to correlate one or the other. Down the track, you might be able to find them.
How old is the youngest patient you've had?
It's a difficult question because I don't exactly remember young patients, but I have seen them in the early 20s.
Early 20s.
And very rarely, I think I might have one or two patients, but it is very hard to diagnose younger patients.
Yes.
And I don't want to put that because a lot of things, stress is coming because of their school and university. I try to avoid put the emphasis on them.
Yes.
Because there might be, it could be even hormonal issues and many other things. So I try to avoid putting the diagnosis on this kind, and I want to give them some time so that they can go forward. But I think early 20s, many people have symptoms. And that actually not too bad because they're very young, they can win their symptoms quicker. Okay? So that is very important.
That's good. No, Dr. I appreciate you coming to the show.
Thank
it's
you
always
very
a
much
pleasure. That's what we do on the Dr. Show. We try to break down these topics, which are big topics, into smaller, understandable concepts. We try to use as simple language as possible for anybody to watch and understand. You can play this video as many times as you want. The main thing is don't diagnose yourself.
That's correct.
Don't tell people that I got fibromyalgia, I got muscle X, I'm tired, exhausted, I'm having poor sleep, therefore I got fibromyalgia. It doesn't equate to that. You need to see your family physician at first instance, get all these, other pathologies that we are talking about, other diseases ruled out, and the doctor would do the necessary steps.
That's correct.
Before you diagnose yourself. We're just here to give information as much as we can. For those who are already diagnosed, They know the condition already. You are just enhancing to what your doctor has already told you. So in the end, it's all about taking control of your symptoms, basically, and engaging in physical therapy, like Dr. Fayez said. That's the main thing, and working on your stress levels, stress management, whatever you can do to reduce the stress. It could be work stress, relationship stress, financial stress. Work on it, because it will just compound your situation. If you're not sleeping, again, get your doctor to help you with the sleep. What's causing the poor sleep? You need to optimize your sleep pattern. And yes, keep well, keep safe wherever you are. God bless you, and thank you for joining us again. Bye-bye.